referring to how often does this condition occur? Modifying, which would be, has anything helped the pain or discomfort? What has the patient done? I applied ice. Everybody see where I'm going with this? Quality of, quality is probably the most important. I came in and I have a really burning sore throat. I'm showing the quality of the pain, right? So I'm talking about the quality of the present illness. Duration. Of course, duration is a little different from timing, because duration, for 2 weeks I've had these symptoms. Okay? So timing actually refers to how often it occurs. So every hour I've had a pain in my elbow for the past 2 weeks. I'm showing two elements here, right?
So duration would be the time that started.
How long the present illness has been. Yeah. I've had a sore throat for a week. I've been having pain in my ankle for a month. So that the time frame in which you're having it. But the timing is every hour, every 2 hours, when I wake up. Can everybody see that? Okay.
Frequency.
Frequency. Great. Okay, so let's see. Next we have the context. And the context is essentially, what is the patient doing around the time that this occurs? And then our last one is any associated signs or symptoms. So again, with the 8 elements of history of present illness, we have the location, which is the specific place on the person's body where the pain is occurring. We have the severity, the pain or discomfort described in a degree. Has anyone heard of the pain scale, 1 to 10? Or you've been asked, can you tell me on a level 1 to 10, what is the pain? I know the name of it. It's like I'm drawing a blank. It's kind of a silly name. Ooh, I almost had it. It is silly. Wang. What is it? Is it Wang?
It's 2 names.
It is 2 names, and I think it is something Wang. Yeah. But anyway, there is a particular pain scale diagram where they have the little smiley faces from the frown all the way up to, that's something that's typical in medical records that you see. Timing, how often does the condition occur? Any modifying factors? Does anything help the pain or discomfort? What is the patient doing? Applying ice, or the quality of the pain? Wong Baker, thank you, that is it. Thank you, Matt. The quality of the pain, so what's the pain like? The duration of the pain, how long has the patient had these symptoms or signs? The context, what's happening around the time that the pain occurs? And of course, any associated signs or symptoms, anything else hurt at the same time. I have a sore throat, my ears hurt, anything associated with this present illness. So those are our 8 elements of HPI. They have to be documented by the physician. Now this is where sometimes you have small elements that may be missed, right? So again, that's where that training of the physician comes in as important. There's a little dialogue in that next slide that you can check out. It pretty much sums up the 8 different elements or questions that examples of questions that may be asked. Our review of systems. Our review of systems, of course, we're still talking about our 4 elements of the history. So our review of systems, again, is subjective. And there are actually 14 separate organ systems within the human body. So there's 14 organ systems. Again, if a patient's coming in with a limited issue, the patient is not going to be subjected to a review of all systems. Makes sense. So the extent depends on the patient's chief complaint. So again, if a patient comes in with the sore throat, they're not going to have a review of their musculoskeletal organ system, right? It wouldn't be necessary. The 14 are listed here over the next 3 slides. So you have all 14. You've got the constitutional, eyes, ears, nose, and mouth, and throat, cardiovascular, respiratory, integumentary, musculoskeletal, endocrine. We've got all 14 listed here. So you can see what all 14 different organ systems are. Our past family social history, it has pretty much relevant information about the patient's history. Any allergies, family history of illness, any immunizations that the patient has had, perhaps even dietary status. So this information is an element, but it's not always necessary, each and every visit. So with our history levels, there's actually 4 different levels in patient history. We have 4 levels. Problem-focused, expanded problem-focused, detailed, and comprehensive. Again, we've seen these before in the CPT manual, haven't we? And of course, each one has its own description. A problem-focused history has a brief history on just the chief complaint. There is a brief history of the present illness, okay? A brief history of present illness would only have 3 of our 8 elements that I listed up there. Can everybody see where the counting's coming in now? So there would only be 3. The review of systems that occurs when it's a problem-focused, or I'm sorry, it has 1 to 3 of those elements for a brief history. My bad. So 1 to 3 on the problem-focused history. There is no past family social history. There's no review of systems. There's a brief history of the present illness. Essentially, that could be going to a provider and saying, I have a splinter. Okay, that is problem-focused, right? They're going to remove that splinter. They're going to probably check out the location and maybe the location, right? Because we know exactly what the issue is and we know what we need to do to remove it. So that's our 1. Of course, 1 to 3 of those elements would be for a brief or problem-focused history. So location, let me fix it for you quick. Expanded problem-focused history, this is where we have 3 of the 8 elements. So an expanded has 3 of the 8. And usually there's 1 to 2 chronic problems with the patient. Everybody, we're going to talk about comorbidities in a couple minutes, but there's usually 1 or 2. When we talked about our associated signs and symptoms, so of course now the patient's coming in and they have that sore throat and they have that earache. So now we're looking at 1 to 2 chronic problems now, right? The review of systems essentially pertains to that chief complaint. Whatever bodily system the patient is complaining about, their chief complaint. That is limits the review of systems essentially to that. For an expanded problem focused history, there is no past family social history performed. It's not necessary. With a detailed history, we have an extended history. We have an extended history of present illness. So now we're looking at 4 or more of the 8 elements. So can everybody see how the complexity is getting a little bit more increased here as we go? There are 3 or more chronic conditions that are presenting. So our associated signs and symptoms were becoming more and more, you know, the patient may have hypertension, diabetes, they may have multiple conditions that each particular problem might be exacerbating the next, right? We have an extended review of systems because we have more than one bodily system now being affected. And we have a pertinent past family social history. Of course, they need to kind of do their homework to kind of find out what may be going wrong with the patient, what might be going on, so. And then, of course, we have a comprehensive history. It's extended. We have an extended history of present illness, so all 8 elements put into play here. We have a complete review of systems, and we have a complete past family social history. On the next slide, there's kind of a nice little table that breaks it down a little bit with our with our 4 groups. And when we look at the CPT manual, you'll understand these groups because that's how we actually apply E&M codes. So we have our problem focused, and it breaks it down so that you have your history of present illness, your review of systems, and your past family social history. So this table is a kind of a good tool to look at to just kind of get an idea of which category it may or may not fall into depending on your documentation. So when we have a hands-on examination of a patient, it's objective. Now we're changing over to an objective view of patient care. There's 4 levels of examination. We have problem-focused, expanded problem-focused, detailed, and comprehensive. Again, we have 4 different levels, and we have 4 different descriptions. These are outlined in the CPT manual, which we'll look at in a minute. A problem-focused examination. We're reviewing the affected body area and/or the organ system. So there are 10 body areas which are based on 1995 guidelines, and of course these guidelines have not changed since 1995. And then we have 12 organ systems. So we have a problem-focused examination would include the 10 body areas and 12 organ systems. I'm going to be passing out a little tool from CMS that you'll be able to actually, I'll start coming around with it now, because this breaks down our body systems for us. And you can use this tool and break it down. You'd probably have to make multiple copies for each chart that you're coding, but it's an excellent tool. I mean, you can always print one. If you're doing an evaluation management code, print one and kind of match up all the different steps up. So if you take a look at the form from CMS that I just passed out, we just talked about our history section. See that in section 1? So that is our first element of E&M coding. And again, you see how we're checking off the 1 condition, 2 conditions, 3 conditions. See how we're kind of using this as a guideline or a tool? And it's essentially, you would be taking this and looking at the patient's record and kind of checking off. You know, when you look at the history and physical of the patient, you can see what review of systems had occurred for that patient. You can look at that H&P and actually use this and check off, okay, yes, the eyes, nose, mouth, and throat, the GI, the G's. Can everybody see that? It's actually pretty handy. And now, what we're talking about now is our examination, which is that second portion on here. And for the examination, you can see how we've got both 95 and 97 guidelines broken down here. So we've got our bulleted elements. So we have our bulleted elements as far as the body systems or organs that are counted into this particular, into the applicable, whatever category, the applicable category for each of the types of examinations. And those four were the problem-focused, the expanded problem-focused, the detailed, or the comprehensive. We'll talk about medical decision-making in a minute, but this really kind of breaks it down for you a little bit, and I thought that would be helpful while we're talking about the 4 levels of examination. So an expanded problem-focused examination is very limited. Again, it's the affected body area or the organs. And they will have essentially the patient's vital signs listed and the general appearance of the patient. A detailed examination is extended. And if you look at this for the detailed, we've got 12 to 17 bulleted items for 2 or more systems, and 2 to 7 body areas or 7 organ systems. Can everybody see that? Of course, our number of organ systems is increasing. For a comprehensive, it's a complete single specialty or complete multi-system examination. So all of our areas would actually be reviewed. Okay? The next in the PowerPoint, the next slide has again broken down into a table the different types of examination and then the different levels, how they would be actually accounted for with the, of course, problem focus would be 1 bodily system all the way up to 8 plus. And again, I mentioned that there were 10 altogether, so. If it wasn't documented, it wasn't done. So the extent of the examination should be documented in the patient's medical record. You should be able to look at that history and physical, the admission note. You should be able to actually pull these elements out and say, that's 1, that's 2, that's 3, that's 4, depending on those different organ systems. Medical decision-making. When we talk about medical decision-making, you know, of course, it's going to be a lot different for that patient that comes in with 1 bee sting or a patient that comes in with multiple bee stings, right? If you think about it that way, the complexity is going to change. So our medical decision-making is going to change based on the complexity of the patient's appearance. There's 3 levels of medical decision-making. First, of course, is the number of diagnoses that they need to treat. What are their management options for this patient? Is it that simple splinter? You know, or is it the patient that's coming in with multiple comorbidities that, or risk of mortality where they have to actually, you know, step it up a beat, right? So the amount of data that has to be reviewed from the physician. Is anyone in here that has done medical records, request for a physician medical records from another healthcare facility, and you end up getting everything but the kitchen sink? You get the entire medical chart? Here you go. The physician has to go through that. The physician, you know, so of course that the complexity is increasing because that medical decision-making, say this patient had gone to 3 different hospitals, and they have records at each of those different hospitals, and the physician has to review all 3 charts. Can everybody see where I'm taking this? Okay. Of course, we have that risk of complication that the patient presents with. What is the risk of mortality? What is the comorbidities? What are they interplaying? What is the risk involved and the complication that's involved? Of course, that is going to require more medical decision-making for the physician. The more complex the issue, of course, the higher the risk.